This conference will now be recorded.
Okay, so I see Jake, Len, Richard Wassersug, Russ Smith, Brian Heisey, Les, Jerry, Dennis Correa, Carl Foreman, Rich Jackson, Ken Anderson, Larry Fish, Sylvester, and Richard Foodie. Is there anybody who I did not call out? All right. So we're going to start. Before I do the roll call, we're going to talk to Dennis because he's not feeling very well at all, and to Richard Foodie because I think he probably wants to get to sleep.
Yes.
He'll tell us about that when he gives us an update. So, Dennis, tell us what's on your mind.
Yeah, it just seems like I got my 90-day Lupron injection. Would have been last Wednesday, and I played golf on Thursday. And Friday started with a scratchy throat, and it proceeded pretty quickly to, full-blown upper respiratory issue. And I was looking at some of my pharmacokinetics on Lupron Depot, the 22.5 milligrams, and it talks about how it very quickly raises the mean peak plasma concentrations shortly after you get it, and then it drops precipitously. I mean, it raises it up to 48.9 nanograms per milliliter after 4 hours, and then declines to 0.67 nanograms per milliliters. And I'm just wondering if this has anything to do with the leukocytes, where the white blood cells that are generally helping your body to resist infection. If this lowers my resistance or something, it seems like after I get the shot, if I go out and just overdo it a little too much, not to my knowledge, I wasn't exposed to anybody coughing, sneezing, and that type of thing out on a golf course. But this thing really slammed me pretty hard, so I thought I'd look into it. I don't know, Len, if you've had any information on stuff like this, or Richard?
I'm afraid I don't, Dennis. I never looked into the pharmacokinetics of Lupron. Those numbers you quoted, were they the plasma levels of Luprolide, or were you talking about something else?
That was the total mean peak plasma concentrations.
Of Lupron?
Yeah.
Okay. That does sound a bit odd. That would plummet like that. I'll be happy to look into it, but off the top of my head, I can't help you with that.
Yeah, I thought I'd raise the question.
Yeah, but I mean, as we all know, these ADT drugs do suppress our bone marrow to some extent. Our hemoglobin and hematocrit usually drop. White cell count could drop. White cells are really involved in bacterial infection, where the lymphocytes are more involved with viruses such as respiratory infections and colds, most of which are viral.
Yeah. And I had my blood work done. And now, is that just on the white blood cell count? Is that an indicator, or segmented neutrophils? Is it those numbers? Because those were all, they were all within range 1 week before I got my injection. So,
what about your lymphocyte count?
Let's see. Lymph percent was 14.4. It doesn't give a range for that. I don't know if that's good, bad, or
that sounds low. What about does it have an absolute lymphocyte count number?
Oh yeah, lymph number 0.93. that one does have a range of 0.6 to 5.5. So you're right, that would be a little low.
Okay. Yeah, I mean, that mine's low also. I think it's just a side effect of the ADT, unfortunately.
Yeah, that's kind of what I figured, which it just decreases your immunity to these viruses to some extent.
Yep.
So
Well,
let me just jump in, because I think you're losing a few of us here. I may not be the only one that's lost. Sylvester, could you just explain that to me, please? So, Dennis, and I'm really just doing this so that we all get a better sense, because you raised
Right. Yeah, I thought I dove right into the details.
Dove right into it, and you left a few of us in your dust there. You know, it was like we were seeing the tail lights of that Porsche of yours.
Yeah.
So you're saying that when you get a Lupron shot, it lowers your, you feel, it indicates that it can lower your white blood count initially, and then it goes back to normal. Is that what you're saying?
Well, that's what I'm suspecting might happen.
And what is it that it actually said? What were those numbers you were saying it actually said?
That was actually of the plasma. Oh, wait a minute. Yeah, the numbers that I read from the Lupron information.
Yeah.
That is the mean plasma concentrations. Once you get it, it's 48.9, and then it declines to a 0.67.
Okay, and what in layman's terms, Len, are the mean plasma concentrations?
well, when a drug is administered, it eventually gets absorbed into the plasma, which is the liquid part of the blood, and it follows, a certain cycle. With Lupron is different than most other types of drugs because it's what they call a depot drug, where it's slowly released over time, as we know, over 3 months.
Right.
Now, I've never, as I said before, I never looked into the pharmacokinetics of Lupron. I have no idea. I kind of assumed that it would slowly be released into the bloodstream and eventually achieve a steady state or constant concentration. Now, so that sounds surprising to me that there would be such a huge rise in the level of the drug in the blood and then a steep decline like that. I'm gonna have to look into it. I really don't know why that would be.
Yeah, and it changes, Len, if you get the 4-month administration. The mean plasma concentrations are as high as 59.3, and they decline to 0.3 nanograms per milliliter eventually.
Mm-hmm.
And then if you go to the opposite direction, if you go with the 7.5 milligram dose for a 1-month administration, mean plasma concentration were 20 nanograms per milliliter at 4 hours, and then 0.36 nanograms per milliliter at 4 weeks. So I don't know what the curve looks like.
If the concentrations are that much greater initially, do we have any idea what that would mean for us?
Well, it's probably the reason why you get a testosterone flare when they administer Lupron or Eligard, because the concentration apparently is so high in the bloodstream that it's causing a release of testosterone stimulating hormones, the LHRH hormones. because it's an agonist, unlike Degarelix, which was an antagonist. So you don't worry about that.
Right.
But so in that sense, I can understand that pattern. And that's why they administer Casodex first to block that testosterone flare.
Right.
But beyond that, I can't comment right now.
Yeah.
So what we
Okay.
don't
But
know,
to me, it makes a little bit of sense to me when I look at it this way, that it does reduce your immunity.
yeah, I mean, what we really don't know is how having a heavier concentration initially of the drug is going to affect your immune system or your blood cell counts or any of that. That's beyond our pay grade here, I think.
Okay.
Anyone else have any thoughts on this or has ever asked their doctor about it? Go ahead, Richard, please.
Okay, so can you hear me?
We
Yes.
can.
Yeah.
Okay, so I don't know anything about the pharmacokinetics there, but just the fact that you had the injection within 24 hours, you're assuming that you had a infection because of suppressed immune system. If that was even common, we would know that, and they would be telling patients who are getting Lupron to stay home, avoid getting going out with these people coughing. The time of it is just too fast for me to think that this is real, substantial, and not known. I'm guessing we just have a coincidental infection you might have at this particular time with the injection. Now, if you have it regularly, then it may be an allergic response to the drug, and it's been presented that way. And it can be not just the drug, it can be the carrying agent. So we know that, for instance, Degarelix, which Len mentioned, is famous for the inflammation that it can produce at the injection site. And there are people, as I understand, who can have, some sort of reaction to the injection. And that makes a little more sense to me than think that you're actually immunosuppressed right now and prone to infection. That would be that explosive that it would come on this quickly. That said, I'll add a little bit to this, and that is there have been at least 2 papers published suggesting that the LHRH drugs like Lupron can increase respiratory diseases. And the 2 papers, one of them was out of Harvard, went on at some great length to try to imagine what might be going on with the lymphocytes and so forth. But there's also another possibility. This won't solve the problem for you on short term, but in terms of the long term, a hypothesis that I believe needs to be investigated, and I've been talking to people in Australia about going after it, is that if we're losing muscle mass, like in our limbs, and it gets harder on these drugs to walk up a flight of stairs and so forth, we can also be losing muscle mass in our diaphragm and our body wall, such that a coughing could be less effective. And it may be that if there is a slight increased risk of bronchitis, pulmonary infections, and so forth, it might be due to weakening of these muscles. That said, that would not come on in 24 hours. That would take weeks to days. So there's several possibilities. One is it's coincidental. 2, it's an allergic reaction to the carrier or the drug. Or 3, it's a holdover of a larger problem with the muscle loss in the body wall and pelvic floor and the diaphragm. Do you need me to unpack any of that? What?
That's logical. I understand. Well, I'm following you.
Okay, well, that's all I can offer to it, which doesn't really solve your problem.
And the only other thing I can say to you, Dennis, is you're the second person I've heard of who's come down with something in less than 24 hours in this area. So, I mean, there's definitely a lot of crap going around right now. And, it is easy to pick stuff up. Somebody had something on their hand and you got it from your golf cart or, picking up someone else's club. There's so many, it's so simple right now. And there's a lot of stuff going around. That being said, I am very sorry that you're sick, and we all hope you get better very, very quickly.
Thank you, guys.
Okay, anybody else like to contribute to trying to help Dennis understand how he's come down with the flu quickly. No. All
My
right.
girlfriend came down with it yesterday and just out of nowhere, 24 hours span, it hit her. Yeah, it's going around.
Yeah. It is.
Dennis, did you get a flu shot?
Most certainly did, and a pneumonia shot also.
Good.
Okay. All right. Well, thank goodness we're not wrestling with the coronavirus here, because otherwise it would be pretty scary. All right, let's move on to Mr. Foodie, because Len and I have been in touch with Richard, and he has a little bit of an update for us. And we also know that he is doing, he's working a pretty full schedule given what he's going through. So Richard, why don't you just give the guys a quick rundown of where you are. I know, for example, Richard Wassersug isn't aware probably of your most recent situation, and then tell us how you're doing and where you are, if there's any updates from what you told us over the weekend.
Okay, thanks. I guess just a brief update. My cancer transformed into neuroendocrine cancer, and in January they found that it metastasized into my liver. So I have prostate cancer in my liver, and my chemotherapy of carboplatin and etoposide wasn't working, so they moved me to immunotherapy, nivolumab, and I've had 2 treatments. It's every 2 weeks, and I was scheduled for a 3rd one last Friday, but it was postponed because my blood work came back abnormal for thyroid measures, although everything else seemed to be good. But of all the side effects, they told me that thyroid side effects are the most common with this particular immunotherapy medication. They checked with an endocrinologist during my appointment, but they decided to postpone the treatment for 1 week. I'll get another blood test on Thursday, and we'll see on Friday if they want to give me treatment number 3. I felt I was pretty lucky with my first 2 treatments. I didn't experience any side effects, but then a week after treatment number 2, I started to experience side effects, and the first one was abdominal pain, and it started out to be intermittent, but then it's been relatively consistent for 2 weeks now. It's all day, it's uncomfortable. I don't have diarrhea, but the frequency of my BMs has increased. They're soft, but not watery or like soup like diarrhea. I'm also been feeling tired and lethargic. And now I did work full time, 8 hours, and I did find myself falling asleep in the morning and in the afternoon at my desk. But I think that the feeling tired and lethargic, that's a side effect of the medication. Although, and then working and, putting that on top of this medication is making it, more of a challenge. So, I mean, that's sort of the big things. And now when I checked in with Len and Rick over the weekend, I found out that what I've been experiencing with my side effects are normal. They're to be expected with the nivolumab. And but it's like I'm feeling sick, the whole day, and it's I mean, like Dennis, it's not pleasant, and it's tiring, and they did not give me any pain medications or any medications whatsoever, and I think that the rationale was that they want to do the blood work again in 1 week and see what's going on. I am going to check in with my appointment on Friday about getting palliative care. And see if I can connect with a doctor who might be able to help me with medications for the symptoms I'm experiencing. And I guess that's it. Mentally, I'm not handling this very well, and so tomorrow I'm seeing a psychiatrist, an MSK psychiatrist. I saw him last fall, and he helped me a lot to get my head, in a good place. And so I'm hoping tomorrow, or it could take several sessions to, who knows, to help me get my head back in a good place. And it's hard to focus when my body's aching, and it's hard to think about things when that's all I'm experiencing, and yeah. So anyhow, so I guess that's it.
So a couple of things come to my mind right away, which is, have you discussed the abdominal pain with your medical team?
I did last Friday, and they were more concerned about diarrhea, not the abdominal pain. A side effect of nivolumide can be colitis. So that's something that I'm not sure how they measure that or how they evaluate that, but there's a huge amount of side effects when you look at this medication. So it reminded me of radiation diarrhea that I had for 8 days last summer. It was just constant and just painful. And but then I had diarrhea. I don't have diarrhea this time, but it's just that pain is there. So, but no, they didn't really talk about the abdominal pain.
Well, I do think, as we discussed and Len suggested, and I wholeheartedly agree, you've got to get a palliative care doc on your team, and that's probably something you can talk about also with the shrink tomorrow, because he's probably my guess is he's probably part of the palliative care service. I know that at UCSF, the psychiatrists are part of the palliative care group. So he may have some ideas of somebody that you can go see and talk to. That should be sooner rather than later. Most of the other thoughts I think you've heard, and I do know that the thyroid issue is common. It was a concern to me, as Len knows, when they first started talking about these drugs. So let me throw it open, Len. Well, before I throw it open, let me pass it to Len, and then we'll throw it open.
Well, Richard and I, of course, have been exchanging emails, so he already knows my thoughts. And I see Richard Wassersug had his hand up, so I'll defer my time to him.
Okay.
Yeah, you're muted, Richard.
I'm unmuted now. Thank you. Richard, I'm sorry to hear all this. You may recall I contacted you about a year or more ago about dragon boating, because we both dragon boat.
Yes.
And I certainly understand why you've been overtaken by the disease here. One thing I don't know is with the neuroendocrine conversion, are any of the theranostic approaches with radionucleotides, such as lutetium, considered available or ineffective? I don't know enough about that. Do you know, Len, or anyone else here?
Yeah, he doesn't produce PSMA, Richard, so
okay,
those therapies aren't available to him.
Yeah, that's of course the first line. You have to have a PSMA avid. Okay, so let me say, the other thing I do know is that in the UK,
Richard, let me just say to you that there is a protein that the neuroendocrine cells produce.
Bombescin.
And Len may remember the name of it. I forget what.
It's a bombescin for neuroendocrine. They can go after it with that. But that's for primary neuroendocrine tumors.
They've been testing it, but I don't think it's anywhere close to prime time yet. No. And we did raise it we raised it for Richard with his medical oncologist, but it's not there yet.
So Richard, can they image the liver metastases, and are they targetable with either HIFU or CyberKnife? That is, in certain cases of liver mets, depending on where they are, they can actually treat them if they're limited numbers and they are in a place where they can get to them. Has that been a possibility? And have you had imaging of the mets? Has there been a discussion about treating them at all?
Well, that's a very good question. They discovered the lesion in the liver in December 30th with a CT scan. Then they had me get an MRI of the liver, and that confirmed that it was only one spot, one lesion. It wasn't in multiple places. And then they did a biopsy. This all happened very quickly, within a week or so. They did a biopsy, and that's when they confirmed that it was metastasized prostate cancer that was in the liver. And as far as CyberKnife or what you mentioned, the HIFU, that was not discussed. The discussion went, and I mean, the discussion was always about moving me into immunotherapy.
Sure, but that doesn't mean you can't go after the mets
Right.
as part of palliative care. I mean, and that's just there's an increasing interest where someone has a limited number of mets. And I don't know whether you have bone mets, and I mean, I don't know what your metastatic situation is in general. But if it's limited, they may be able to actually, treat the liver met. And some of the symptoms you're dealing with, gastric distress, can be part of the actual liver mets and not the drugs. It could be both, one or the other, or both. And given that, there might be a case for being aggressive about actually trying to treat the liver mets, even if you have metastatic diseases elsewhere. I mean, just for the palliative palliation. I'm for anybody who doesn't know me, I'm not an MD. So these are just another patient throwing out ideas.
Right.
Richard, we did discuss, Richard Wasserstug, we did raise with Dr. Rathkopf the possibility of radioembolism.
That's another example, yeah.
With surspheres or something similar to the surspheres. And Richard, what was it? You did talk to her about it, and what was it she said about using the surspheres?
Len, you were on the call when we talked about that, right?
Yeah, she was not in favor of that approach. I think she felt that that procedure has been used for primary liver cancer, and she's not aware of or has no experience with treating prostate cancer metastasized to the liver with that approach. So she was not interested in that. Yeah, I believe that in her opinion, this was I mean, given that we have neuroendocrine cancer in the liver metastasis, that this Opdivo or nivolumab therapy was his best option.
And she,
I mean, she's a smart lady. She's up on all the latest research. You know Dana Rathkopf at Sloan Kettering, Richard Wasserstug?
I do not.
Okay.
I'm on the other side of the continent up here in Vancouver.
Yeah.
I'm far away from New York City.
Yeah. And she also did a consultation, like a second opinion consultation with Dr. Charles Drake at New York Presbyterian, who's a leading oncologist in immunotherapy, and his office agreed with her assessment and her plan.
Right.
So, but like Len, with what Richard said, do those ideas would they be worthwhile? I'll be seeing Dana on Friday. Would it be worthwhile to bring it up to her then, or?
Well, you have nothing to lose. I don't think she'll be receptive, but sure, why not bring it up with her?
I think the context, the way in which to bring it up with her, Rich, is to say, look, I'm wondering if this abdominal pain may have anything be at all related to the liver. And, you know, we've talked about some focal treatment on the liver before. What do you think of that idea? Can we revisit it? Do you think that this abdominal pain is related to the liver? And you know, that would be a reasonable way for you to reintroduce it.
Yeah, that's a good idea.
And as Len said, you know, I wasn't on that call, but Len sure did a great job with you. And, you know, it sounded like when we talked about those Surspheres or similar product to Surspheres, which for the rest of you are kind of like little radioactive marbles, and they use them to treat liver cancer. And I've known of one instance where it was discussed for treating liver mets in prostate cancer. But it sounds like she wanted to shelve all of that to see if we could get a result out of the immunotherapy drug, out of the nivolumab, Opdivo.
Yeah.
But I think everything's on the table, you know, ask her.
Yeah.
Richard, is the immunotherapy protocol you're going to be starting a in standard practice, or is it part of a clinical trial?
It's standard practice. I don't believe I'm part of a clinical trial. They never brought that up.
They would have told you.
Yeah. So it's the rationale for this for nivolumab, it was because it was effective with neuroendocrine lung cancer.
Yeah.
Right.
So there's a ton of the immunotherapy protocols that are under investigation, and it would not be inappropriate to ask if there are any other clinical trials with combinations of some of these other drugs. I know this from what's going on in Canada, and I would imagine that at the Memorial Sloan Kettering there are more options for clinical trials than there's in all of Canada. And that's certainly appropriate. No harm in asking, as Len said.
Yeah. Well, I think that what the plan is that I'll be getting another CT and a bone scan end of March. That'll have been about 3 months, or maybe mid-March. I'm not sure. But so they would assess the situation based upon that imaging.
What is, I mean, I guess you've been discussing this, Len, and I'm new to this, but what is your metastatic load right now? And what are they, besides your liver, do you have imageable bone metastases and bone pain as well?
Yeah, I have 2 small bone mets, one in my sternum and one in the right iliac, which seems to be a common place for bone mets with prostate cancer. So I've got 2 of them, and they've been unchanged for 4 years.
Okay.
And then the prostate gland, I still have mine. And there was a little bit of tumor activity outside of the prostate gland around the urinary system parts. But that got cleared up with the radiation.
Richard, FYI, I think we mentioned it to you, but this response of neuroendocrine apparently has been recorded, I don't want to say often, but it's been noted in several occasions where people have had exceptional success with enzalutamide like you did. Which I didn't know before, but somewhere or the other I found that. Len and I talked about it, but you know, you got 4.5 years out of enzalutamide, and evidently people that do very well on enzalutamide, the way the cancer adapts is it takes on this small cell neuroendocrine like form. So that's just a sideline, but it's obviously relevant in your case.
Yeah.
Let me open it out a little bit. Is there anyone else that would like to say anything to Richard of any sort, of any sort of message?
Well, I mean, I'll speak I think I speak for the group. We all hope you the best. We wish you the best here. We hope
Yeah.
that you come up with a good treatment.
Absolutely.
Yeah, I second that. Glad you
uh,
got to speak with Drake because he's a smart guy.
Yeah, thank you. Thanks, Ken, and thank you to Richard Wassersug. The only other thing I did want to raise with you is, you know, I know that you had the discussion with your supervisor, so she is aware. And as I mentioned to you, if you do decide to speak to your MD, your boss at MSKCC, she's going to know a heck of a lot about nivolumab because it's used very frequently in lung cancer.
Yeah.
So it might be worth sharing with her because she may have some ideas. She may have used it a lot more frequently than Dana even, because it's been used in lung cancer for at least 3 or 4 years now. You know, I want you to baby yourself. 8 hours is a lot, Richard.
Yeah.
And you know, maybe if you can get to if you can cut it back to even 30 hours, it might make a big difference for you.
Yeah. I mean, I was thinking about that. It's I mean, it's when cancer was in the background, and you know, everything was being managed well, I didn't bother me working at Memorial Sloan Kettering and then going and getting my treatments. But now, and that was every 3 months. But now it's like, you know, every week, every 2 weeks. You know, so I mean, you know, some people I see, you know, they see me with an employee ID, and sometimes they don't. They see me without an employee ID in a treatment room. So
Yeah.
it is stressful. You know, it's like I'm too immersed in Memorial Sloan Kettering, both as a, you know, as a patient. I think it might be better if there's a separation between being a patient and not being an employee, unless I was able to get moved to a place that's not, you know, patient centric. But you know, I don't know. It's kind of a weird place. It's a really weird place.
Well, Richard, I know if I recall correctly, your primary motivation for wanting to work is just to keep your mind off of your illness. But for years, you weren't working and you still had the illness, and you managed to keep yourself busy or keep your mind active with other things. Do you
Yeah.
feel that you can't do those same things now because they were too physically demanding? Or could you keep your mind off of your health issues with activities other than working, things you could enjoy and do at your leisure? Give yourself that extra amount of rest.
Yeah.
I guess I'm just something to think about.
Yeah, I think it's possible. I'm really looking forward to being with the psychiatrist tomorrow because, you know, when in January when I learned that the cancer, you know, spread to my liver, you know, my mind went in the worst places possible, and it was on the dark side. It was not, you know, so it's been a challenge to be positive and find hope. And you know, it's very easy to think of the worst case. And so, and even with work, the work does help keep my mind off of that, or having some sort of an activity does help keep my mind off of that. So maybe I'll learn something tomorrow that can help me as well. But singing and things like that, I was starting to learn how to play the piano. And that was definitely something you can't be thinking about cancer and learning how to play the piano. But then as soon as I stop, my mind shifts back. So I've got to do something about that shift back and find out how to deal with that.
Richard, have you had to change your diet with the immunotherapy considerably?
No, I've been eating a plant-based diet, vegetables, fruits with some protein, primarily chicken, eggs, cheese, and that's fine. Nobody has said anything about my diet.
Okay, well, we need to, Richard, we need to move along. Certainly, Len and myself are no further away than the end of a telephone call. So you can call us anytime. And hopefully you'll get a little satisfaction from the psychiatrist tomorrow. And, I'd like to see you get set up with a palliative care doc so they can start seeing if they can help you with some of this nausea and abdominal pain and the side effects of the nivolumab.
Yeah.
Keep us posted, or keep one of us, keep Len posted. He'll keep me up to date. But reach out for us if you need us.
Will do. Will do.
Okay.
Thank you very much. I'm going to head off to bed now. I'm tired.
Understood.
So
Good night, Richard.
And good night, all.
Okay, good night. Good night, good night. Okay, I'm going to take a quick roll call and see who would like some time tonight. And we'll start with Len.
I could give a PSA update.
Okay. Jake, anything for you tonight?
No, Rick, nothing for me.
Okay. Richard Wassersuk, anything you'd like to talk about tonight?
I'm physically okay, but I also would like to give a little report on the efforts to expand the ADT educational program beyond Canada.
Okay.
I might be happy to talk about that.
That's good.
2 to 3 minutes.
Okay. Russ Smith, anything you'd like to talk to us about tonight?
You're muted, Russ.
Sorry about that, guys. Yeah, just a quick update. I met with my local MO today. First time I met with her, and starting on as soon as the prescription comes through. I'll give you an update later.
Yeah, we'll come back to you. Excellent. Excellent, excellent. Brian Heisey, anything you'd like to bring up?
Yeah, I'll just give an update. I haven't been on this call for a while, so.
Super. Okay. Les, anything for you tonight?
Maybe a quick question. Yes.
Okay. Jerry Pelfrey, anything for you? Mr. Pelfrey.
Yeah. No, nothing to bring up tonight.
Nothing for you. Okay. Carl Foreman, anything for you tonight?
Hi. So we kind of left it off at the last call about my question about dealing with pain. And I know you had mentioned that could be a very long conversation. So I can defer that to another time because we're already an hour into this call and there are a number of people who need some time. So I leave that to you.
Okay. So I'm going to put pain and we'll see how much we get into that. And if not, it'll be next time. Promise.
Okay.
We'll elevate you. Mr. Jackson, all quiet on the Eastern Front, as quiet as it can be?
So quiet and just waiting.
Okay. That was a sort of I barely heard you there, but I think you said we're just waiting. Is that right?
Yes, just waiting.
Okay. Ken Anderson, anything for you?
No, I'm all good tonight.
Okay. Larry Fish, anything for you, sir?
No, thank you, Rick. I'm good tonight.
Good, good. Sylvester, anything you'd like to talk about?
No, thank you very much.
Okay. And Peter, anything for you?
Yeah, I have a quick update, a couple of questions regarding chemo.
Okay. Have I touched base with everybody or did I miss anyone? All right. All right, let's I'll jump around in different ways here, but let's start off with Len's PSA update.
Sure, I'll be very quick. So I had I think it was about 5 weeks since my last PSA, which was 0.09. And again, it came in 0.09. So I guess maybe a little disappointing it hasn't continued to go down, but at least it hasn't gone up. And it was a different lab. I don't know if that has any effect. You know, they always say you should always stick with the same lab. But in my case, being down in Florida, I had to find a new doctor. And so I had to use a different lab. But next month, I'll be using the same lab. So we'll see what the comparison looks like. And just a quick refresher for everyone. I've been on Lupron and durolutamide for about 5 months now, I believe. So one other blood change was I appeared to have lost close to 1 gram of hemoglobin. I was about 13.8, now I'm about 12.8 since restarting the ADT 5 months ago. And as we said before, this is not unexpected. It's happened to me before when I was on ADT, and I know it's happened to Peter as well, and I'm sure a lot of guys. And that's it for me, Rick.
Thanks. Any questions for Len on his results, durolutamide, anything else?
I was reading earlier today on one of the I think the whatever it is, Euro Today things. There's a study in the Netherlands, maybe, where they're trying to relate low hemoglobin to serious aggressive prostate cancer. Use it as a tracker or indicator, and they pretty much feel that they can tie the two together based on that study.
Yeah, I mean,
Can somebody translate that for me? I'm sorry, Peter, I just can't hear you very well.
Yeah, Peter said that there was a study he was listening to on Euro Today from the Netherlands that has tried to correlate levels of hemoglobin with the degree of seriousness of advancement of the prostate cancer. And it seems like there is a correlation. And I was just going to say that, you know, I have seen men, the sicker they get, the lower their hemoglobin falls. But you know, we sort of know that some of that has to do with the prostate cancer getting into the bone marrow.
Right. Well, with the PSA of less than 0.1, it's unlikely that bone marrow involvement is causing that drop. I think it's more just the ADT.
Yep.
Bone marrow suppression.
Yeah, bone marrow suppression and anemia, and it is pretty common. Anybody that's been on long-term ADT, including myself, and it's just, it's there. All right, let's.
Can I ask a question?
You may.
Is hemoglobin the same as hemoglobin A1C?
No.
Okay, unrelated. Okay.
Yeah, really quite unrelated. Hemoglobin A1C is used to measure long-term blood glucose concentrations.
Okay. For diabetes, right? I
For
knew
diabetes.
that. I was just checking to see if you guys knew.
Keep us on our toes, Jake.
You're muted, Richard Wassersug. You're muted.
One is a measure of a particular molecule, and one is the amount of hemoglobin you have overall. So they're very different in that regard.
Okay. Thank you for the clarification. Okay, we'll move right along. Russ Smith, you had a review of meeting with your doctor today.
Yeah, if you remember, I think February 5th, I went to the first time Dana-Farber in Boston to meet with my main medical oncologist there. I'm going to have my treatment done locally. Just for people who weren't on the other call, that I'm 1 year post RALP, and my PSA's gone up to 0.09, and it was time to make a move. So I met with Dana-Farber in Boston on the 5th. It was confirmed that they believe that the cancer is still there. So I'm lucky enough to have a Dana-Farber branch in my hometown, about 3.5 miles away. So that's where the Lupron and the radiation will take place. So I met with a local medical oncologist who's just kind of be the coordinator, and meeting with my radio oncologist in the next week or two to begin planning the radiation. But between then, I got my first prescription for Lupron ordered today, and the first shot will be in 2 weeks. So, that's on to a new adventure for me. So up to this point, it's only been surgery, and so just another background is my score was 4+3, 11 to 12 samples were positive. Also positive in the right seminal vessel. So it's on the low end of advanced. The cipher is 0.66. So I want to be proactive and be ahead of it rather than catching up. So that's all I have.
So I have a couple of things from this. By the way, it's you were very close. It's Lupron as opposed to Lupron. Okay, the P and the R you need to switch around, but that's okay. Unfortunately, it'll be coming out of your mouth so many times. Believe me, you won't forget it going forward.
It's all new now.
Now, what I am concerned about is, have they talked about giving you bicalutamide first?
No.
Well, it's fairly normal, and I'm surprised they haven't, especially since they're at Dana-Farber. And is this Dr. Roberts you saw, or is Dr. Roberts at Dana-Farber?
I saw they're both Dana-Farber, and I saw Roberts in Boston, and I'm about 38 miles north of Boston in New Hampshire. So I have a Dana-Farber here where I can get my radiation done.
Well, I would strongly recommend that you send a note to Roberts right away, or Sweeney, and say they want to start me on Lupron, but nobody has discussed bicalutamide. Should I be doing it? And let me explain to you why.
And tell me what it is, yes.
It is an anti-androgen. It's a drug that kind of clogs up the androgen receptors. It's an old drug. It's been around for a very long time. There are much newer and more effective drugs. We've talked about some of them tonight, like enzalutamide and darolutamide. But initially, it can work. And the reason you need it is because the way that Lupron works, it stimulates the testosterone before it reduces it. It's called an agonist.
Yep.
Thank you, agonist. I almost got it. It's an agonist rather than an antagonist, and what that means is it stimulates the testosterone to the point where the testicles cannot keep up with the demand for testosterone, so they switch off. So you get what's called a surge in testosterone initially. Right. And the concern is that if you've got any metastasis anywhere in your body, micro, that they may not have picked up, this big surge, in testosterone could cause something to happen. And so they give you this bicalutamide for about 10 days to 2 weeks around the time that you're starting the Lupron so that it acts as a buffer. How did I do, Dr. Wassersoog?
You did well, but I think most people would know that. Allow me to do a pitch here. Russ, I'm going to show this. There's a book out called Androgen Deprivation Therapy written for patients. You can see that on the screen. I strongly recommend it. Plus, if you go to the website associated with this book, it's called www.lifeonadt. The people who put this book together offer a free class. It's an hour and a half, uses GoToMeeting platform, which you already know how to use. The next class is in about 3 weeks. And this book is not alternative therapy. This book is formally and the class endorsed by the Canadian Neurologic Association. It's run up here out of Canada. And if you go to that website, you'll see a paper just got published showing that this program, this educational program, significantly reduces the side effect distress for patients going on ADT. Okay, full disclosure, I'm an author on the book. We offer these classes nationally in Canada, and my report was to tell you about the fact what we're doing to try to expand the program to Europe and to Australia. But it's exactly for people like you who are starting these drugs and want to know what all the side effects are and know how to deal with them. And you can buy the book ahead of time. Like, if you're in Canada, you get a book for free, but unfortunately, because that's how the drug companies support the program nationally. But it's like the ebook is like $15 on Amazon.com. So I really recommend it.
I'll get it tonight or tomorrow. Thank you.
Yeah. Now, if you have a partner, we suggest very much that the patients and partners read the book together.
Thank you.
There you go. Was that all right, Rick?
Yep.
Absolutely. I'm delighted that you were able to get that in. And I'll also send you, Russ, if I didn't already, the UCSF hormone therapy pamphlet.
No, I didn't get that.
Okay, so I put Russ Smith. I'll send that to you, which is something that we put together at UCSF many years ago. It's been revised. And in conjunction, it's not as thorough as Richard's book, but it has been very helpful to very many men. And you can download it. I'll give you a link, and it'll be a link to a PDF, and you can print it right off on there, or you can read it online. So,
sounds good.
But the one thing I definitely want to tell you, and it's disappointing that your medical oncologist didn't raise it, is that the bicalutamide is important.
Okay, I will. I'll make an inquiry tomorrow.
Okay, and by the way, the other name for bicalutamide, the trade name for it is Casodex.
Casodex?
Yeah, Casodex, Casodex, or bicalutamide.
Thank you.
And it's a very cheap drug. It's generic at this point.
And all the use of that is discussed in the book as well. Why you use it and so forth.
Yep. All right. Anybody else like to give any words of advice to a man about to embark on LHRH therapy? We have a lot of old heads here. Say something to this poor chap. He's thinking he's going to be walking around with a pink handbag and pink high heels very soon.
I bought a bra today.
There you go.
A couple of things. First of all, going on ADT is not the same as going on estrogen. All right, so there is actually, in Europe, there's a clinical trial using high dose estrogen. And in that case situation, a bra might be effective or appropriate. So it's not, it's crashing your hormones. It doesn't, it may be emasculating, but it's not feminizing the Lupron. Secondly, the side effects are, this is one of the facts that I've squeezed in anything I say about this. And that is that it's been shown, so almost for 25 years, for research out of Memorial Sloan Kettering, which we heard before, that the distress from from us men being on ADT is actually more stress, and it's more stressful for our partners than for us. So that if you have a partner, please let her know, because the book is written for both patients and partners. And one of the biggest things I'm concerned about is when us patients lose our sex drive, we abandon our partners, they're freaked out, they don't know why, and then our problems become their problems. So that's all. There's a couple of chapters in the book that talk about the impact on relationships, sexuality, and so forth. And that's meant for both patients and partners.
And I would just add, Russ, that don't freak out if you start reading about all the possible side effects to ADT, Lupron, because guys have widely varying reactions and tolerance for ADT or Lupron, any testosterone lowering drug. Some tolerate it well, some don't tolerate it well at all. So hopefully you'll be in the group that tolerates it well, but don't just read and say, oh, I'm going to have this problem and that problem. Not necessarily.
Yeah, one of the best predictor, though, of some of the side effects in terms of who gets them, who isn't, is age. So the patients who are 85 years old, as you get older, your testosterone naturally declines. So if you go on a testosterone suppressing drug, the difference is not very great. If you're 50 years old, the hit is typically harder. So I've talked to hundreds of patients on these drugs, and in agreeing with Lynn, I don't think I've seen anybody who's really experienced all of them, but the book discusses which ones are serious and which ones aren't. And if you're not exercising yet, start exercising. Physical exercise, and Lynn is nodding in agreement. And I think Rick would say the same.
Very important.
That's exactly what I was going to say. Russ, I'm a year and a month out. I've been on Lupron ever since mid-March of last year with Zytiga and prednisone. And I'm one of those lucky guys. I mean, I get the hot flashes, but I got to tell you, I don't get them when I'm really exercising and walking. You'll see that through all the literature that you read, and you may think, oh, they're overemphasizing it. They're not, believe me. So good luck, and you'll make it.
Well, the good news today is the doctor, and I am very active, and the doctor says, good news is you're young. I'm 58, and I exercise. I'm also a baseball umpire and a football official for high school. So I keep very active. So at least it's the one place you can go to and hear that you're young and in good shape. compared, I guess.
Russ, one thing that I would suggest is that before you start, you get the first Lupron shot, ask them to measure your testosterone. Okay, and a lot of times they don't do that. And there are some doctors who don't even think it's important. But the reason we like to have that number is because it gives you a baseline. And then you know when you come off and your testosterone starts to come back, whether you've gotten back to where you were in the first place. It can be a very helpful number.
Makes sense.
So, and it's not always done. So just tell them you need to know your baseline testosterone before you start your therapy.
Yep, that's good idea.
Okay, let's keep moving. Go ahead.
I just said thank you, guys.
Oh, pleasure. And keep coming back. We'll keep supporting you. There's loads of tips and all kinds of stuff. Like you just found out today, all this great information.
Definitely.
Okay. Brian Heisey.
Hi.
Hello.
I can't remember the last time I was on this call, but I have been on the under 60 call and provided some updates. But it's kind of where I'm at now. At the end of June last year, my PSA was starting to rise after I had some radiation earlier in the year, some spot radiation. And it was at 1.1 at that time, and we made the decision to, finally start a second-line hormone therapy, and I started abiraterone at that time. The PSA dropped immediately to 0.4 in the next month and stayed around there for about 3 months, and then it has gradually increased every month by a small amount, probably about 0.2 a month. So right now I'm back at PSA of 1.1 as of the end of last month. So I did meet with my local oncologist about a month ago, and he wasn't too concerned about the small rises. So we're going to continue to monitor it and see if it, levels out or what's going on. That's it.
Okay, so you've now been on Lupron, on Zytiga for about 6 or 7 months. Is that right, Brian?
That's right. That's right.
And initially you got a good response from it, but now you're sort of back to where you started, right? Didn't you say you started
right
around 1.1 when you?
That's correct. Yeah.
Okay. Let me throw it open to anybody that would like to talk to Brian about that progression, or any thoughts or questions for him.
Brian, can you give a little more background on your Gleason score, primary therapy, the extent of your disease when you were first diagnosed?
Yeah, I'm sorry. So I was diagnosed back in 2017 with metastasized prostate cancer. I had Gleason 9 score. At that time, the PSA was at 25. And initially had Pharmokinetics, and then started chemo, did the 6 rounds of docetaxel, and I had a very good response to that. The PSA went down to undetectable for a time period of about 2 years ago. It was undetectable for a time period of a few months, and then it started gradually rising. I had some spot radiation, and every time I had the spot radiation, the PSA would drop back down. And I had done that 2 or 3 times. Different spots were showing up, and different types of radiation. One time proton, the other time was SBRT. And then it was this last time, about a year ago, I had another round of some spot radiation, some new spots, and again, it had dropped the PSA, but then as of June last year, it had started going up again and had hit 1.1, and that's when we made the decision to go on to the second line hormone therapy, because it really didn't want me to do any more radiation, at least at that point.
Have you ever had any mutation analysis done on your prostate biopsy or anything subsequent to that?
No, I've had twice. I've had the Garden 360 test, which is a blood test. And last time I had it was probably about 9 months ago, and nothing showed up with that, and nothing had showed up the time before. And then I did have, some germline testing done, just the color test done way back, and there was no indication of any specific, issues there in regards to the genetics.
What about a prostate biopsy when you were first diagnosed?
In regards to the, what specifically?
Well, you said you were a Gleason 9, so I assume they did some sort of pathology analysis of your tumor at some point. probably when you were first diagnosed, didn't they take a biopsy of your prostate?
Yes. So that was, I think it was, there was Gleason 7 in one cord, Gleason 8 in a couple cores, mostly Gleason 9s throughout all the cores. Almost all the cores are positive. And I had that analyzed twice actually, and basically came out with the same results.
Okay, but what I'm suggesting is that it might be helpful to have a genome sequencing done on that original prostate biopsy. There may be some actionable mutation, maybe not, but there could be, and that could dictate your next form of treatment. I'm not sure you want to stay on Zytiga much longer, since your PSA has been rising while you're on it.
Mm-hmm.
Yeah, I don't know so much about the original prostate. I mean, do you have any metastatic spots right now?
The last time I was scanned was in October, and that was at the time the PSA was around that 0.4, I think maybe 0.5. And there was a couple spots, but they had decreased from the previous scan when the PSA was higher. And one of those spots was a spot that had been radiated before.
Mm-hmm.
So that, we didn't want to do any more radiation on that spot.
Right. I mean, ideally, if you've got a lymph node or a metastatic lesion that they can identify, I think you're much better off biopsying that than you are going back 2 years ago to your prostate. You say your prostate biopsy was in 2017 or 2016?
It was in 2007, early 2017, so about 3 years ago.
Yeah, so, I think if you could, especially since since then you've done some chemotherapy, correct? And you've done Zytiga and you've done a whole bunch of stuff. So you would be better off getting something more recent. And, and maybe if you do fail, sending that away and getting that interpreted.
Okay.
It's definitely a good idea on Len's part.
I was thinking he probably doesn't have any more recent specimens, since they keep spot radiating his bone lesions, presumably bone lesions. You never had a bone biopsy, right?
No, I never had a bone biopsy, and I've never had any involvement with the lymph nodes, so there was no soft tissue. So I'm due to go back and get scanned in April. So I guess I'll see what that shows and see where my PSA is headed, or
some people do get a response from enzalutamide after abiraterone. I don't know how much we know about apalutamide or darolutamide after abiraterone. We do know that darolutamide works around several of the mutations that the other drugs do not. At this point, would you consider Quan to be your quarterback?
Probably, I don't know. I guess my local oncologist has been playing more of a role. Just because that, I haven't gone to, I did take a break from going back to Quan I took it was going to be a 6-month break, assuming that there wasn't going to be much movement in the PSA, because there wasn't in the first 3 months. And, I can always shoot them a note and see what their thoughts are, as well. But I will have another PSA test coming up here in another week or so.
I know we've talked about this before, and I know you have a history and a backstory with Northwestern. But have you ever met with Alicia Morgans?
I did, actually, I did meet her briefly at the conference in, when was that? October or November?
Right.
She was,
yeah.
Yeah, she was the moderator.
Yeah.
So I just met her briefly, and she seems, nice enough. So, I think about it more.
Look, she's very smart. She's very compassionate. She has a good manner, as you know. And I really would like, if it were me, I'd really want to have a good GU med onc running my game at this point in time. And now's a good time to bring somebody on. And and I think she's a great alternative. You've also got Maha Hussein there. You've got what's his name, Walter Scheidler, isn't it, down at U of C, and a couple of other guys down on the south side. But my first choice would be Alicia. I think she's great.
All right. Well, I will take a look at see how things go here in the next month or two, and I'm not going to let it get out of control before I do something.
Hello. Sorry, is everybody there? I think I've lost my audio.
Hello?
Here. Hello? Yeah, I'm here.
Yeah.
Yeah. So, that would, Len, what's your thoughts on that?
I'm sorry. Are we talking about on whether or not he should see Alicia Morgans?
Or, just finding a GU med onc right now for instead of Quan at this point.
Yeah. I like Alicia Morgans. Quan is a urologist basically who loves to use choline, C11 choline scans very often, too often.
Yeah,
I do have a medical oncologist here locally that I'm working with, and I do like him a lot. So, that's more who I'm working with right now. But again, if things aren't going right, I'm not getting the right answers here in the next month or two, I definitely will look at other options.
Brian, is he a GU? Is he a genitourinary? Did he consider himself to be a genitourinary medical oncologist, or is he just a general medical oncologist?
I think he's a general medical oncologist, but he does treat a lot of Quan's patients.
Okay. Well, the best advice I can give you and anybody else that comes on here, and it isn't medical advice per se, is that with advanced prostate cancer, you need a genitourinary medical oncologist running your game. And, we just feel very strongly about that. And we know that people have got best results by following that, but we can only give you our input. Anyone else want to comment on that?
Where do you live, Brian?
I live outside of Chicago.
Okay.
So, but you know, don't hang around too long. If it's turned the corner and it's moving up, and you've gone from 0.4 to 1.1 over 3 months. Yeah, it's time to have another discussion, Brian, and let's find something that works for you. There's a lot of stuff out there right now.
All right, I appreciate your comments. Thank you,
Everyone.
everyone.
One possibility is Chuck Ryan. He's only an hour and a half above Quad to go to Minneapolis.
Yeah, Chuck Ryan's another great alternative. You know, he's in Minneapolis, which is a little further away. You know, there are a couple of decent guys at in Madison as well. But you know, I don't think you have to look far much beyond Northwestern, really. All right. Ken Anderson, this is for Les and Sylvester. Ken writes that Great Nonprofits requires you to log in and set up an account prior to posting. So you have to register on the Great Nonprofits site before you post a response. So you might want to try that. See if that works. Evidently, you can't just go on. If you're not known to them, you can't go on and write a review. You have to register first on the site, and then after that, you can write a review. So that might possibly solve the problem. I'm going to put in the chat window. I'm going to put in the chat window exactly what Ken sent to me. Thank you very much, Ken, for tracking that down. Okay, Les, we just mentioned your name. What's up?
Okay, I've had about 8 of those choline PET scans in the past. In books, and Dr. Eugene Kwan had indicated several times that with Gleason 10 that you may not have a PSA rise as your cancer returns. Now, with my history, each time in the past that my cancer would return, my PSA would rise first. You know, each time that PSA would go down as the to undetectable following the treatment, which is surgery or whatever. Anyway, my question is, if in the past there's been some direct correlation between the PSA and the cancer returning, is there any way of believing that that might continue? What I'm trying to do is cut down on the number of these PET scans. Like I said, I've had, I think, 8 now. And I did postpone the last one I had scheduled for, or they were going to schedule for May. And we've pushed it out for an indeterminate time for right now. But I'm wondering if you have any history of, say, with the Gleason 10, if you experience a correlation between PSA and the cancer returning, if there's any correlation there. End of question.
Yeah, and I'll throw this one open to everybody and to Len, to Richard Wassersuch, but I will say this: your cancer has responded to treatment. it responded to, I mean, you were on Lupron for quite some time, and your PSA was driven down to less than 0.1 or 0.1, and it stayed around that 0.1 level. So whilst you are a Gleason 10, we also know that, you know, it's quite likely you still have adenocarcinoma. In other words, it's hormone, it responds to hormone treatments. And what was your original PSA? 24.8?
Yes.
So you do make PSA. You know, if you would have said to me originally, well, my PSA never got over 5 or 6, I would have a lot more concern. Again, we're not here to give you medical advice. What we are here to tell you is that we often see men whose PSA rises with high Gleasons, like Brian, who we just spoke to, and, you know, they need to adjust their treatment. So, you know, if you're afraid that just monitoring your PSA alone is not going to be sufficient, you know, I think that's a discussion that you've got to have with your doctor. The problem is that with somebody like Quan, he's going to keep urging you to come back, and you don't want to come back. So maybe you've got to add somebody to your medical team. I don't know what to say. I don't want to keep banging on Quan, but it is a concern. Len?
I agree 100% with what you said, Rick, and also I'm not sure I have anything to add except getting a second opinion from a GU medical oncologist about the need for another scan, and if so, what type of scan would be most appropriate, especially considering you're concerned about tumor growth that isn't producing PSA. So in other words, what type of scan is best for someone who's not producing PSA? What is your PSA right now, Les?
0.1. It's been that it was less than 0.1 for some time, and then it went to 0.1, and it's been that for the last, I think, 3 or 4 times now. I get PSA every 6 weeks.
Right. And you're currently on ADT or no?
No, I'm not. I stopped a few months ago. I think my last one was last March, 1st of March.
I have July 19 is when you stopped in my notes here.
I think that's when the 3-month run out.
Okay.
So I think the last shot was in March.
Okay.
And you have no symptoms?
No.
And your testosterone is recovered?
It's up to 398 was the last one.
Well, it's hard to know what to say. I would be thinking that you're probably doing well, and at least for the time being, your cancer is in remission. It's dormant.
Right.
Is there a possibility that it's growing and it's not producing PSA? Yes, but I don't know what the odds are that that's the case.
Yeah. Well, I was wondering, since in the past, it's always there was a correlation. Every time the PSA would go up, they'd check it. Sure enough, you got cancer coming back. There was always a correlation. Whether that will continue or not, I don't know. You know, my decision had been with Dr. Kwan to postpone doing another PET scan, and I was hoping that that was the right decision.
Yeah.
That's the correlation has always been there for me. You know, my PSA sits there at less than 1, and but I track it like a hawk, and I track it every month, and every time it's crept up or jumped up or whatever, even at a low level, I've done 2 scans, 2 PSMA scans, and I keep watching it. So for me, there is a definite correlation there, even at a low level of PSA. It's something's on the run. So if yours has not done anything yet for 4 months, I just keep watching it, and as soon as
How
it
is that?
does jump, or loop or whatever it does, whether it's 2 months from now or 6 months from now, I'd get a scan in.
Yes, right. Okay, that's enough. Thank you very much.
Well, I think that as long as you're monitoring it every 6 weeks, the only other way, are you getting any other blood tests? Because there are other indicators. Are you just testing PSA?
Just PSA and testosterone is all I've been checking.
I don't know enough, but it might be worth asking your medical team whether they want to check some of the other measures, the ALK or something like that. ALK or phosphatase? What's that? Richard? What's the phosphatase measure?
I think he dropped out, Rick. Alkaline. It's alkaline phosphatase.
Alkaline phosphatase. Was that the one that was used before PSA?
No, I think before PSA they were using something called prostatic acid phosphatase. Maybe that's what you would think.
What I was thinking of. Yeah, alkaline phosphatase and yeah.
Yeah, that's something you can ask them to check for you as a biomarker. Less PAP, prostatic acid phosphatase. Another one would be chromogranin A. That would be a biomarker for neuroendocrine, which is not likely, but I guess it's worth monitoring if you're worried about no PSA being produced.
Okay, all right, thanks.
I had one question. Maybe I missed it. Did you say how often you get scans?
Well, I've had 8 so far, so it's been probably every 6 months, something like that. I started, I think, in 14. Was my first one, 2014.
So, I mean, I think you should discuss with your doctor, but it does certainly seem like you can just, like Peter said, watch how often can you get PSA every 3 months and maybe every month. It's not expensive actually, but to monitor your PSA very carefully and take scans every 6 months, and maybe like Len says, ask for that neuroendocrine cancer marker and not do any ADT fraud. Not think about ADT at this time. I don't know. Somebody else?
Larry, I don't think the issue is so much about wondering whether I should go back on ADT. I think the challenge for Les is how does he monitor himself if PSA is not a good measurement for him, because the doctors put it in his mind that PSA might not be a good measure, and he doesn't want to keep getting scans. And that's the critical issue. And that's what we're wrestling with. Because if he goes back to the doctor's just going to say, yeah, we'll just keep scanning. But Les isn't totally comfortable with that. So we're trying to come up with other proxies beyond the scanning. That's why we've suggested a couple of the other markers that might pick something up if there was something going on outside of the PSA. But you know, it sort of bothers me a little that the doctors put doubt in your mind about the reliability of the PSA, but we've been running your disease on the basis of PSA for the last 5 or 6 years.
Yeah, so
So,
I've read that too in books that when you're up to Gleason 10, that the likelihood of having no correlation is much higher. So I was just wondering what your experience has been with that. My decision has been to postpone. I'll still probably take the PET scan again, keep doing it, but rather than 6 months, maybe do it every 9 months or so.
Isn't the development of neuroendocrine cancer most likely the result of other treatments that cause the, if it wasn't initially, that caused the morphing of the cells, so if you're stopping ADT and you haven't had any changes, isn't it unlikely that you would develop neuroendocrine? I mean, what is the probability and how is it related to stopping ADT? I'm just curious, like how low that probability is.
I certainly can't answer you. I mean, I think that probably what we're saying is that if you've got very aggressive disease, then it's more likely that you're going to have some variants where you might not produce a lot of PSA, which isn't the case for Les, or your disease might morph in response to treatment, like Richard Foody's case, where he did 4.5 years on enzalutamide, and then the disease found a way around it and became small cell-like or neuroendocrine-like. But none of those are really appropriate in Les's case.
Right, and if you're hypothesizing that the Gleason 10 indicates increased probability of possibly developing additional variations in the cells, and what will be if the PSA doesn't go up, and now you're saying you've developed an additional variation because it's Gleason 10? Is that based on the fact that you've been treating Gleason 10 aggressively with other things? Or if you're not treating it at all, what is that possibility? I don't know if anybody knows, but maybe a endocrine specialist could answer a question.
I mean, I don't know. I mean, I think that Les, I think you have some ideas as to how to proceed. I mean, would I go to a neuroendocrine specialist and ask him, does he think my disease might have characteristics of neuroendocrine disease with a history like Les? I probably would not. Is it out of the question? Probably no either. Anyway, let's move on. We've sort of dragged enough out of this, and Les, I think you've heard several sides of the coin. I don't know that I think we probably confused you more than we've helped you.
No, I think you answered that you do not have anything that would counter what I have been doing. So I think that answered my question.
Right. Now, the fact is you weren't able to write that review because you probably hadn't registered. And now you got to register. And I'm just wondering whether today's session's got us a worse or a better review.
It would still be the same.
You don't have to answer, Les. You don't have to answer.
It would still be the same. I think it's still the same.
All right. Thank you. Now I don't feel so bad. All right. Peter has some questions on chemo.
Yeah, well, first off, I got my port installed on Thursday morning, or Thursday afternoon, yeah, Thursday morning. I was able to do it without any anesthesia. So they just put some uh, local lidocaine on it, and so I was awake the whole time and able to drive myself home. They didn't tell me that ahead of time. They told me I had to arrange to have someone drive me home and I'd be out and all this stuff. But once I got there and talked to the doctor, they said, no, a lot of people do it without any anesthesia. So I elected to do that. It was no problem. So that means that chemo cannot be far behind. So I think, I don't know if anybody on the call has been doing or gone through chemo. A few have, I guess. So I've got a couple of quick questions. One is, because I've never been through this before, I've watched people. But one is I'll be taking docetaxel and carboplatin. Are they done simultaneously? Are they mixed? Does one come after the other? I don't know. And I was wondering if anybody knew any of that, the answer to that question.
I have an idea, but I'm not certain. Does anybody know? Has anybody done both, and do they know the answer?
Okay.
So, I'm pretty certain they give you the docetaxel, and then they wait a certain amount of time, like half an hour or 40 minutes, and then they give you the carboplatin. They're done consecutively.
So it could be a long stay during. I'll check. I'll ask the question and check it out. Nobody seemed to know when I was there, but I will just go.
That's what I recall from people that have done Foodie's done 2 different drugs. How long? I don't know how long the docetaxel infusion usually takes. Can someone tell me who's Ken or someone else who's done the docetaxel? How long does that or Brian? How long does that docetaxel infusion usually take?
It's about 3 hours. Well, from start to finish, you get there. It probably takes about an hour and, I don't know, 25 minutes or an hour and 15 minutes for the infusion, but they want to get you there early and do blood work to make sure everything's cool before they start the IV. And so I gave it all up.
The actual infusion, how long does the actual infusion take for docetaxel?
I'd say about an hour and 15 minutes.
Yeah, I've got a feeling.
Yeah, that's what I was going to say too.
Thanks, Brian. I've got a feeling the carboplatin's around 40 minutes. Don't ask me where that comes from, but we'll see. So I think that you're looking at, probably that 3 hour-ish mark plus another however long it takes for the carboplatin.
Okay. Another quick question is, we discussed this before, but I probably wasn't listening when we were discussing it. And that's it. If you take a break, longer than every 3 weeks, if you have to make an adjustment, like 5 weeks between session 3 and 4 or something like that, is there any downside to that, or is there hard and fast stuff that has to be clockwork every 3 weeks, or does it not matter?
Well, quite honestly, Peter, if you're not allowed to take it because of blood work, they're just not going to give it to you, so it won't really matter. I mean, if you have to skip a round of chemo because you can't take it, you can't take it. So I guess hopefully that answers your question.
Yeah, that makes sense. Okay. This has to do more with scheduling, perhaps, than blood work, but I'm just.
I know they like. Hi. I know they like to stay on schedule. If you're having trouble managing it in general, they can sometimes lower the dose a little, or they can try. Some people, put you on every week to try with a third of a dose. There are variations they use, but I know they like to do it. If you're doing it, they like to do it as best you can.
Okay.
Get it over with.
Okay. I think those are major questions I had. I don't have anything else to put. I guess I'm going to start probably before the end of the month. Or probably early next week is my guess. So.
Well, our thoughts are with you, Peter. I'm sure you'll fly through it, and just, we don't want to sound like a broken record on this call, but do as much exercise as you can, because it really does help. I mean, you know, scale it down. Don't expect you'll be able to do what you've been doing, but don't stop it altogether, and it'll help you. And we've heard so many people tell us that. We've advised it, and then they've come back and said they really felt that it helped.
Right.
So,
Peter, I would also ask the oncologist who's administering the chemo, since carboplatin has a fairly high incidence of causing peripheral neuropathy, you might want to ask, you know, at what point, if I start feeling or having peripheral neuropathy, how much further should we push this without risking permanent neuropathy? So I'm talking about this because I remember with Dominic when he was, I think it was carboplatin he was taking.
Yeah,
it was like his second round of chemo, and he was taking carboplatin, and he started getting neuropathy, and it was getting worse. And, you know, iron horse that he was willing to continue, but his doctor said, no, we've got to stop. In the interest of his quality of life, he was concerned about the extent of the neuropathy. And in fact, he did have long-lasting neuropathy. He was never able to alleviate that. So it's a good question to ask up front. I would do it anyway.
I will.
Ken, when did your neuropathy first start showing up as a result of the chemo?
You know, I was, as you stated, exercising a lot, and I was actually working around the yard, and around the 5th round, I noticed it in my feet, and I thought I had bruised my heel or something by kicking a boulder or whatever that was I was doing.
Yeah.
But the fact is around the 5th round, it showed up, and I might even, and I've read up on it since I had those 6 rounds, and I must admit, when I before I ever started chemo, I did a lot of research, and there was a bunch of guys that, you know, were out there 10, 15 years that did chemo, and they said they did, you know, the ice gloves to slow down blood flow within their hands, and did, you know, ice on their feet to slow it, and trying to slow down the chemo from settling in extremities. And I would do it. If I might be crazy and the doctor might say, no, it won't work, but I'd still do it. Today, I would do it, because having to take gabapentin 900 milligrams every day is just a pain in the butt. It's just one more drug. So maybe it'll work, maybe it won't. I have no idea.
Yeah, I plan on doing it. I'm going to do some research tomorrow about whether I can bring dry ice into the hospital.
No, you can't take. You probably can't take dry ice into the hospital, but you can do like frozen ice. They make these mitts that you can get wet and put on your hands and freeze, and there's all different kinds of products that they have out there. But you can also just use, you know, a bag of ice and stick your feet in a bucket. You know, they may think it's crazy, but I would do it because I have neuropathy, and if I should have taken the guys that told me their advice. At least I would have crossed it off my list, even if it didn't work.
Yeah, I've enrolled, oddly enough, across my email this morning came an announcement of a course at the local university here on a 6-week course on Qigong to fight neuropathy, specifically for the hands and feet. So I've enrolled in that.
Well, lots of luck. Keep
Yeah,
us posted.
I know.
Keep
Peter,
us
even
posted.
even better, we hope you don't get neuropathy so you don't need to enroll in it.
Right, well, I've enrolled, it's free anyway, so I don't care.
Oh, okay. Can't be that then. Maybe you can teach us. That'll be it. We'll make some videos for us, some Qigong videos for us.
Okay.
Anybody else want to say anything to Peter about any thoughts or words of advice on the neutropenia issues? I know a couple of the guys of Larry's, Dennis is no longer on the call because he was feeling rubbish, but anyone had any neutropenia issues from the chemo? Brian, didn't you finish up?
Yeah, this is Brian, Peter. I did have some. I still have some peripheral neuropathy. It's not over time. It kind of waned. It was mostly in my toes, but I don't think I have it as bad as Ken did. But yeah, I would recommend doing something if you can to try to see if you can reduce it. Because initially, yeah, it was bothersome.
Okay. I will work on that.
Didn't you have, Brian, didn't you have some neutropenia issues though with your white blood count or something?
I've had my blood counts have been low ever since I've been doing all the various treatments. But no, I took Neulasta during chemo,
right?
As a precaution. Yeah.
Okay. Well, yeah.
That's standard of care. Neulasta.
Yeah.
Okay.
Did they put that thing in that automatically injects you 24 hours later?
Oh, so you're going to get that newfangled pump thing that goes in your arm?
Right.
Okay.
Yeah.
Good. Okay. All right, guys. Well, Carl, I'm sorry we didn't get to the pain issue, but because we did have a bunch of guys, and Richard Wassersu dropped off, but not before he managed to get the plug-in for his book, which I'm really happy he did, seriously. So we'll have to get him back on to tell us how he's extending his ADT education program to Europe and North America. I'm going to actually ask him if he'll do a little blog post for us. And we will talk about pain as soon as we have a less busy meeting. But yeah, that's it. So let's see, Monday, next Tuesday is the 4th Tuesday, the 25th. I have this new big old calendar here, as you can see on the wall. So courtesy of our insurance agent. So the 25th is when we'll talk to you next week. I wish you all a good week, and we'll speak to you then.
Night, everybody.
Good night, all.
Everyone.
Good night. Good night.
Good night.
Good luck, Peter.
Yeah.
Okay. Yeah.
Good luck, Peter.
I'll let you know.
You don't know when, huh? You haven't no indication when you're going to start?
I have to do an orientation. That'll most likely be this week. They know that I just had the port installed. I got a couple of stitches taken out of the port on Thursday morning. I suspect I'll have the orientation this week and probably start next week.
Okay. Okay. Just make
Well,
sure you keep a girl in every port. That's what I say.
Right. Okay.
Okay.
take
All right.
care.
See ya.
Okay.
Bye.
Yeah. Bye-bye.